Good evening. Will there be any mega grand revision happen for the upcoming examination? So, guys, I must tell you that DBMCI is already conducting one this FMG. Yeah, so DBMCI is already conducting this FMG one shot series where all the subjects are being revised, right? So all our faculties have taken that session, and I think we have completed the program also. So if you want to see any of the subject, कोई भी subject किसी को देखना है, so they can go to the DBMCI channel, the YouTube channel, and they can see all the FMG one shot revision plan. Okay, so Mr. Faujdar is there. Okay, Guruji Ram Ram, Farhad Zabeen, good evening. Hi Zabeen, good evening. Hi, Faujdar. Good evening. Okay, so I think we are live and we should start now. Okay, so everybody, I hope that you all have got the PDF of the session, right? So I'll just see a few charts. Okay, okay. So I do believe that everybody has got the PDF, right? Everybody has got a printout of the papers, all these 10, 11 pages. And this session is going to cover up all your important images which are expected in your exam. Okay, and all those images as well which have been already been asked in your previous year exams. So let's see how to remember all the images and how to answer the questions of all of them. Good evening. Hi, good evening, everyone. So let's start with this. So the very first slide, very first image that you have is the image of a child, some patient who has got his forearm or her forearm actually deviated towards the medial side, right? If you get this kind of question in your exam, you know this is a very, very important topic. This is a very, very important topic, and you all should know that the first word to be used for this joint, what is the first word to be used? It is cubitus. You all know that it is cubitus. And after the cubitus, when you look at this forearm, this is going towards the medial side, right? So cubitus, and when the deformity happens with the limb going to medial side, what do we call it? We call it varus. So this deformity should be called as what? The first word for the elbow and second word for the deformity, that is cubitus varus. The question is very simple, image based question, that what deformity this is. So if you can identify the deformity, wonderful. And then second question will be definitely that where do you see this deformity? So please remember that this deformity is seen in fracture supracondylar humerus, right? Whenever there is an injury supracondylar area, the humeral part getting fractured, then we see cubitus varus deformity, which is also called as, what is the other name for this? What is the other name for this? The other name will be gun stock deformity, right? That is the other name we have for cubitus varus deformity. So please remember how to identify the deformity. That is the part of the limb distal to the joint going medially. Part of the limb distal to which joint? The elbow joint, right? And the word for the elbow is cubitus. So cubitus varus, the cubitus varus deformity. All right, perfect. Second one, when you see the second image, here again you can see that the joint involved is elbow. So again I'm going to use the word cubitus, right? And the forearm, the part of the limb distal to the joint, is going which side? It is going on the lateral side. So cubitus, the part of the limb distal to the joint, is going laterally, and laterally means what? Laterally means valgus, right? Part of the limb distal to the joint is going laterally, right? This lateral deviation is what you call as valgus. And where do we see this valgus? Part of the limb distal to the joint is going laterally. Valgus, where do we see that valgus? This valgus, okay, this valgus is seen in when there is a fracture lateral condyle of humerus. When there is a fracture lateral condyle of humerus bone. But you should remember that lateral condyle has got one very, very typical complication related to it. What is the most commonest complication of these two fractures? Please remember that as well. That is another MCQ. So when we talk about supracondylers, the most commonest complication has to be malunion, right? Please remember it has to be malunion. Union तो होगा ही होगा, confirmation है, union होगा ही होगा, that is malunion. And the lateral condyle fractures, they usually get what complication? They usually get a complication of non-union. So malunion and non-union. Okay, right. So malunion and non-union. Please remember that. So malunion, supracondylus; non-union, lateral condyle. Do remember this. Very, very important images. Very, very important topics for your exams. All right. Very good. Let's come on to the third one. Third image we have is the joint involved here is which one? The joint involved is knee, right? The joint involved is knee, and the word to be used for knee is genu. And the part of the limb distal to the joint, part of the limb distal to the joint is going medially. right? It is going medially. So when it goes medially, what do you call it? When it goes medially, what do you call it? It is called varus, right? So genu varus, where do we see this kind of deformity? You know very well that it is usually seen in elderly patient. Now if you can tell me something very very quickly, where do you see this deformity, everyone? So this is seen whenever there is a osteoarthritis in elderly of the knee area, obviously. So osteoarthritis in elderly, right? So OA, genu varus. And if you look at the other deformity, other one is again the knee getting involved. So it has to be genu, and this one has to be the part of the limb distal to the joint is going laterally. So it is called as valgus, right? Genu valgus. Where do we see genu valgus? Any point, any topic you remember? So genu valgus can be seen in the cases of rickets. Genu valgus can be seen in the cases of rheumatoid arthritis, the windswept deformities, you remember? So genu valgus. So please remember how to define the deformities. Out of these four, the most important would be definitely the slide number 1 and 2. No questions, like no doubts on that, right? These two are the most important ones. All right. Let's see the next one. The slide number 5 is showing you 5 X-rays, right? And you know very well that what we are talking about. What we are talking about? We are talking about the fractures of the physeal area, right? Fracture of the physeal area. How do we classify? Can somebody tell me the name? How do we classify that? Classification for physis injury. Classification for injury to physis. Physis, the growth plate injury. How do you classify? The classification is Salter and Harris classification. It is Salter and Harris classification, you remember? And how do we recall that? How many types of injuries are there in Salter Harris? So in original Salter Harris, there are 5 types of injuries. In original Salter Harris, we have got 5 types of injuries. What are those? If you remember the mnemonic was what? Salter, right? So just see this diphyseal area of the bone, metaphyseal area of the bone, and the epiphyseal area of the bone. And we are talking about injury to this central structure, right? That is physeal area. Now, when you just talk about the mnemonic Salter, the first word S is for same level injury. Remember that? The first word is for same level injury. Same level means injury somewhere in physis only. Injury somewhere in physis. And if you see your basics, your notes of the basics of bone, you know that physis, the growth plate has got 5 zones, right? And please remember, where do we get the most commonest injury in the physis? It is the zone number 3. Please do remember that. That is zone 3. And what was that zone? Zone number 3. Look at your notes, and that was zone of hypertrophy. Please highlight this. This is very, very important. It has been very recently asked in your INI set examination also, and it's a very basic thing to be asked in your exam as well, right? So same level physis is the zone 3. Okay, 5. Azhar is right. Absolutely correct. Okay, you are absolutely right. Okay, so everyone from Delhi FMG batch, I'm just looking forward for your responses also in the group, waiting for your responses as well. Okay, so you all, yeah, perfect. Okay. Second injury, the S after S, the second word is A. A here stands for what? A stands for above. What is the area above the physeal area? What is the area? This is physis, right? This is physis. I must put it here in the very, very thorough manner so that you are not confused. I'll put it here. The second image, the second one is here. The first one is here, the 1 and 2. This is for A. Now A is for above. Above means what? The injury to physis and the part of metaphysis. You can see the dot here. So physis and metaphysis. And what do you call that fragment here? What do you call this fragment which I just shaded here? This fragment is called as what? What do we call? It is called as the Thurston Holland fragment. Remember that? This is called as the Thurston Holland fragment. Okay, that is called as the Thurston Holland fragment. Remember, the type 2 injury is physis and metaphysis. A, S, A. Then we have type 3, L. This one is the third one. It stands for L. L here stands for lower. And what is a part of the bone below the physis? What is a part of the bone below the physis? That is epiphysis. So physis, look at this, the physis and epiphysis, that is type 3. Type 4, type 4 is SALT. The T here stands for total. All the 3 layers will be involved. So epiphysis, physis, and metaphysis. Right? All the 3 layers are gone. That is epiphysis plus physis plus metaphysis. And 5 is ER. Right? ER. ER stands for what? Eraser. It stands for eraser or crush. So it is the crushing. It is the crushing of the physis. And definitely, when there is crushing of the physis, it has to have the worst prognosis. Any child who is going to have the type 5 injury definitely will have a damage to the growth plate and the growth will not happen. Okay, so out of these five, I want you all to remember the two most important. Number one, the injury, now the recent year question of INI, so you should know that, right? Second, the Thurston Holland fragment, that is very, very important, which is seen in type 2. And the worst prognosis is of which grade of Salter Harris? It is type 5. Okay, so what was the mnemonic we said? The mnemonic is Salter. How we made the Salter? S, the A, L, T, and ER, right? Salter. So Salter is a mnemonic type 1 to type 5. Okay, so please do remember these two. They are very, very important. The type 1 has been a recent question, and type 4, this one, the SALT, right? The 4 will be having everything. Type 5 is a crush. Type 3 is epiphyseal, and type 2 is again very important. That is Thurston Holland. That's very important. Then you see this kind of x-ray which has been a repeat of almost like multiple times in your examination. Okay, if you find any patient in your exam where you can see one side of the contour of the shoulder is maintained and other side the contour is lost, and then you can see a bony prominence over here, what exactly is that? This bony prominence has to be what? It has to be acromion. The bony prominence has to be acromion, right? And where do we see that bony prominence? Bony prominence means the contour of the shoulder is lost, and loss of the shoulder contour is seen in anterior dislocation of the shoulder. It is seen in anterior dislocation of the shoulder. So if you find any patient in your exam where the contour of the shoulder is lost, bony prominence is there, that has to be the acromion, and that is anterior dislocation of the shoulder, right? That is anterior dislocation of the shoulder. On the other hand, when you see the contour is maintained but upper end of humerus is giving you a globular appearance like this, where does it happen? The contour will be normal here. Please mind this point. The contour will be normal here, right? Here the contour is is normal. The contour is normal, and this appearance of the humeral head, which is absolute round, is called as what? The electrical bulb sign. It is called as the electric bulb sign, right? That is called as electrical bulb sign. So contour is normal, electrical bulb sign. Where do we see that? This picture will be seen in the posterior dislocation of the shoulder, right? So in your exam, if you get a question where they say that the patient had a history of fall and after the fall he is not able to mobilize the shoulder, but the contour of the shoulder is maintained, you know very well that you're talking about posterior dislocation, because contour will be maintained and x-ray is going to show you some very, very typical sign. We call it as the electrical bulb sign, right? That is electrical bulb sign. One of the very repeated question of your exam, very number of time it has been repeated after this dislocation around the shoulder, is a picture like this, right? Now in this picture we can have two problems or two issues. Okay, what exactly we can see here? You can appreciate that the left scapula of the child is on the upper level, right? And the left side is at upper level, right side is a lower level. There is discrepancy in the position of the scapula. There is a discrepancy in the position of scapula. It is high riding scapula. Where do we see that? This is a failure of descent of scapula. When the scapula is developing, at that time the scapula has failed to go down to its proper position, and that is failure of descent. This failure of descent of scapula is called as what? This is called as Sprengel's shoulder. This is called as the Sprengel's shoulder, right? When you can see that the level of shoulder is again at the different levels. That is Sprengel's shoulder, the failure of descent of the scapula. Now, this can be associated with the syndrome where the cervical vertebrae are fused, right? And then because of this cervical vertebra getting fused, the neck is not there. There is not much of the length of the neck, and then the spine may become scoliotic like that. So if somebody has got a neck cervical area, the bones are fused, the vertebrae are fused, and there is a scoliosis. That is called as what? That is called as the Klippel-Feil syndrome, right? That is Klippel-Feil syndrome. What is that Klippel-Feil syndrome? Klippel-Feil is the fusion of the cervical vertebra. Because of that, there is no length in the neck, and because of that, there is a curve on the back associated with the failure of descent of scapula, and that is called as what? clipal fail syndrome. So Sprengel is just failure of the descent of scapula, and clipal fail will be the syndrome which has got scoliosis, cervical spine fusion, and the failure of descent, that is Sprengel shoulder. Okay, and it has been asked number of times, so you should all be aware of this problem, right? That is, yeah, Sprengels and the clipal fail syndrome. All right. Then we have the next one. Next one. Okay, okay. Now this is again, I would say something important which has been repeated in the recent years in your NEET and INI exam. So I want everybody to be very, very careful about this. This is what we see around the elbow, and what do we call it? It is called as a simply 3-point relationship, right? It is called as the 3-point relationship. Now, what is that 3-point relationship? It is made by these 3 points. You remember, olecranon, lateral epicondyle, and the medial epicondyle. Lateral epicondyle and the medial epicondyle, right? When I flex my elbow, you can see these 3 points on the back of my elbow area, right? On the back of my elbow area. Okay. Now they ask you the question that they ask you the question that in which cases the 3-point relationship is maintained. In which case do you think it should be maintained? So 3-point relationship will be maintained in which fracture? The fractures which are not going to touch. The fractures which are not going to touch the 3 points. That means the fracture happening here or below the olecranon. So what is a fracture which happens above the condyles? We call it simply fracture supracondylar humerus, right? About which we have discussed one of the point above as well. So supracondylar humerus. Okay. Second point is they may ask you what are the conditions when this triangle is broken? What are the conditions when this triangle is broken? Okay. In which conditions this triangle will be broken? It will be the fracture lateral epicondyle, fracture medial epicondyle, or fracture olecranon, right? Or flexure olecranon. Okay, so these are 3 points. So when any of the 3 point will be broken, when any of the 3 point is broken, the triangle is broken. It's as simple as that. Okay, because 3 points are making the triangle. So any fracture, any point which is making the triangle, if broken, the triangle is broken. It will be as simple as that. All right. So this is your the triangle being broken. Then this next image is just the replica of the first image that we had. Now I want you to emphasize upon here the only issue, the only difference is the deformity is same. The deformity has to be same. Here the joint involved is elbow, so I'm going to call it again cubitus, and the forearm is going which side? It is going medially. Right now I wanted you to have a comparison of the image number 1 and this image, because here the problem is it is same cubitus varus which you see in malunited supracondylar fractures. Now the problem here is that this boy is not standing in the anatomical position. So be very, very careful about this. When you look in your exam, if you have a deformity where the child patient is not standing in the anatomical position, don't get confused, right? The problem with the image is here the child is not standing in the anatomical position. Okay, so first image, if you appreciate, it was your varus. Okay, and the child was standing in the anatomical position here, so you're able to make it out. But in this image he is not standing in the anatomical position, so you will not be able to make it out, right? So be very, very careful while you mark the deformity. Don't mark this one as valgus. If this kind of picture comes to the exam, don't mark this as valgus. All right, the cubitus valgus and cubitus varus should be very, very clear. Now identify this injury. If you can identify this injury, anyone who can answer this? Okay, Priyanshu was right. Okay, Klippel fail syndrome. Okay, Shamli. Azhar, what is the diagnosis? If you can make out the diagnosis in this particular X-ray, can you make out the diagnosis here? Can you make out the diagnosis here in this particular image? What is the diagnosis? Okay, what is the diagnosis here? If you guys can make out. So what you appreciate here? The proximal part of the bone, the distal part of the bone, and the injury here in between them, the lower end of humerus. This is the radius. This is the ulna, and you can see this is the elbow joint. Right? This is the elbow joint. All right. What is the diagnosis here? Injury above the condyles of the humerus. So what is the diagnosis? The fracture supracondylar humerus. The fracture supracondylar humerus. So you should be able to identify. Now, when you look at this image, you should be able to identify which kind of supracondylar is this. When you look at the elbow, the lateral view and the AP view, lateral view and the AP view. So you can very well identify that in the image A, it is a lateral view. And in the lateral view, you can very well appreciate that. In the lateral view, you can very well appreciate that. Okay, yeah. In this lateral view, the distal fragment is towards the posterior aspect. When the distal fragment is towards the posterior aspect, what do you call this? What do you call this? When the distal fragment is towards the posterior aspect, what do you call this? Okay, so, all right. Okay, this is called as the supracondylar which type? Extension type. Okay, and you know very well that majority 98% of the injuries supracondylar humerus, they are extension type only, right? They are extension type only. So supracondylar fracture humerus, they are of extension type only. All right. Yes, this is 98% time. Now this is B picture. When you see, it is the AP view of the supracondylar area. This is the AP view of the supracondylar area, and what it is going to show you again, the ulna, the radius, and the distal end of the bone which is having a fracture over there, right? This is the fracture supracondylar area where you have the varus deformity. 3-point relationship will be maintained, right? And malunion is the most commonest complication. Look at the slide number 11. In the slide number 11, you can see the ulna, the radius, and a fragment of the lower humerus, which is getting separate from the base, right? This fragment is displaced lateral condyle of humerus. This is displaced, this is displaced lateral condyle of humerus, right? This is displaced lateral condyle of the humerus. And you know why it gets displaced? Because there is an attachment of what group of muscles? These are the common extensors, right? These are common extensors. And now, because of these common extensor, what is happening here? Because of this common extensor rotation, the fragment does not stay connected to the parent bone. And when it is not getting connected to the parent bone, what is going to happen? As the child will grow, the medial side keeps on growing, right? And the forearm gradually goes laterally, developing what deformity we said? Developing the valgus deformity. And as the valgus will keep on increasing, what will happen? The stretch will come onto the medial side. And under the medial side, this medial epicondyle, what is the most commonest nerve we have? It is the ulnar nerve. And that's going to create a stretch of the ulnar nerve after some time of the injury. And that is why, what do we call it? The lateral condyle related to late involvement of the ulnar nerve. So tardy ulnar nerve palsy. Okay, tardy ulnar nerve palsy. All right, the tardy ulnar nerve palsy. Okay, so this is tardy ulnar nerve palsy. You should know the lateral condyle is related. Yeah, Prachi, absolutely correct. It is tardy ulnar nerve palsy. Perfect. So you all should be very, very clear that how the lateral condyle is related to what kind of injury. You should be very, very clear with that. Okay, so tardy ulnar nerve palsy. Then we have two most important injuries. Then we have another important set of injuries in the elbow area and forearm area. So here, what do you see in this image? What do we appreciate in this image? That humerus is here, ulna is here, radius is here. What has happened here? What has happened in this particular image? This image is elbow dislocation, right? This image is elbow dislocation. And what kind of dislocation should I call it? Is it anterior? Is it posterior? What should I call it? The proximal part is humerus, which is staying anteriorly. Distal part is radius and ulna, and they are going on the back side. So elbow dislocation, which is posterior one. So this is posterior dislocation. And please remember, whenever any patient has got a posterior dislocation of elbow, along with a injury to the radial head, plus injury to capitulum, then what do we call it? This is called as the terrible triad of elbow. This is called as the terrible triad of elbow. In the recent year examination, there has been a question on the terrible triad of knee, and this one is a terrible triad of elbow. The triad because of three things here: elbow dislocation, radial head injury, and the capitulum, right? And the capitulum. So this is the posterior dislocation of elbow and terrible triad. And please remember what it does to the 3-point relationship. Please remember what it is doing. The 3-point relationship here, it is going to be reversed here. It is going to be in reversal. So, okay, so this is going to be reversed. Perfect. Olecranon, no, it is not olecranon, Prachi. It doesn't have to be olecranon. It has to be elbow dislocation, radial head, and capitulum, right? Olecranon involvement is not there. So 3-point relationship that we said, the olecranon, lateral and medial epicondyle, this olecranon from here, it moves here. So these 2 points stay here only, and this is going to move, right? That is your elbow dislocation. The other two most important injuries in the forearm area, which you can easily make out now, is the slide number 13, which is, you can appreciate here, the fracture of proximal one third of ulna. Fracture of proximal one third of ulna. What do you call it? Can you name it? And there is a dislocation of the radial head. Dislocation of proximal radio-ulnar joint, and in that proximal ulnar joint, there is dislocation of the proximal radio-ulnar joint. And you know where the will that in the radio-ulnar joint, it is actually the radial head which is dislocated, right? It is the radial head which is dislocated. What do you call this injury? What do you call this injury now? This injury is called as, yeah, Priyanshu, absolutely correct. This injury is called as Montegia, right? This injury is called as Montegia fracture. Perfect. This is a very, very important question for your exam, and n number of time it has been asked in past as well. Okay, so fracture of proximal one third of ulna with dislocation of the proximal radio-ulnar joint, right? Then we have another injury in the forearm, the opposite, reversal of Montegia. See, the fracture of distal one third of radius, fracture of distal one third of radius, fracture of the distal one third of radius, and you can appreciate here this ulna here, if you can make out this ulna getting dislocated. So dislocation of distal radioulnar joint, everything reverse of the previous x-ray. Dislocation of distal radioulnar joint, and what do we call that? What do we call that? This is called as Galeazzi. This is called as Galeazzi, right? So Montegia and Galeazzi. So dislocation of the proximal one third and distal one third of radius. This is Galeazzi and Montegia. So Galeazzi also is called as what? The reversal of the Montegia, the reverse Montegia. Okay, that would be reverse Montegia. Perfect. That has to be, yes, that has to be reverse Montegia. So Galeazzi and Montegia, two very, very important images for your exam. Then we have two most important images again from the trauma section. And what is that? These are two images which you can easily make out here. So just see this. Just see this. This is the shadow of the thumb, right? This is the shadow of the thumb. Okay, shadow of thumb on both the sides. And that simply tells you that this is the anterior aspect of the wrist area, posterior aspect of the wrist area, anterior aspect of the wrist area, posterior aspect of the wrist area. And what do we appreciate here? The distal radius. Can you make it down? The distal radius here, it is facing on the palmar side, and distal radius here is facing on the dorsal side. So what is the diagnosis here for both the x-rays, for both the images? If you can make out both the images, the first one is Colles or Smith. What do you suggest? Should I write Colles or Smith? Which one is Colles and which one is Smith? Please mark that. The image A and image B, which one should be Colles, which one should be Smith? If you can make out. So how do we differentiate between Colles and Smith? How do we differentiate between Colles and Smith? As per the displacement of the bone, right? So when it is a palmar, yes, Prachi is saying Colles, Priyanshu says Smith. Okay, what about Azhar? What do you have to say? Like, what is the diagnosis here? So diagnosis has to be made on the basis of on which side the fragment is going. If it is a palmar displacement, it has to be which injury? It has to be Smith. And if it is a dorsal injury, it has to be Colles. Now look at the images, in which one the fragment is going on the back side, in which one the fragment is going on the front side. Okay, so in the X-ray A, what is happening? Yes, Priyanshu is right. In X-ray A, the fragment is going in front, so we are going to call it Smith. And on the X-ray B, it is going to go on the back side, right? So that has to be dorsal displacement, it has to be Colles. Okay, so please remember Smith, Colles, the distal end of radius fractures, and Montegia and Galeazzi, right? The Montegia and the Galeazzi. Now, when you talk about the deformities, in the Smith, you can see that fragment has suddenly gone anterior like this. Okay, the fragment has suddenly gone anterior like this. So in the Smith, what is the deformity called as? This deformity here in the Smith is called as garden spade, right? This deformity is called as the garden spade deformity. Okay, and in the Colles, you can see that the fragment is going suddenly on the backside. Fragment is going suddenly on the backside, and this deformity in the Colles is called as what? It is called as the dinner fork deformity. It is called as the dinner fork deformity. Okay, that is called as dinner fork deformity. So garden spade in Smith and Kohli's has got the dinner fork deformity. Yes, absolutely correct. Azhar, Amit, you should be absolutely able to differentiate between the Smith and the Kohli's injury. That's very, very important. The two images which, like, sometimes are confusing just because you forget that how to identify them on the basis of their displacement. So palmar side, how to identify it as a palmar side? Look at the shadow of the thumb. Look at the shadow of the thumb. That will be very, very easy for you. If you're ever confused, it will be easy for you. All right. Okay. Just see the next one. Just see the next image. Here, what do we see? The two images are showing you. The two images I showing you. Yeah. Okay. Now in this is radius, this is ulna, this is scaphoid, this is lunate. You can see in the image A, you can see in the image A, there is not much of the like gap between the scaphoid and the lunate, right? That is image A. But when you look at image B, can you make out that the scaphoid and lunate, they have some space in between that? Can you make out? And what do you call that sign? Can somebody name it? Can somebody name it? When there is a scapholunate dissociation, when this ligamentous area it is broken between these two bones? No, that is not scaphoid fracture. This is scaphoid and lunate. This is not scaphoid fracture. What do you call it? Whenever the scaphoid and lunate they move away from each other, what do we call it? The scapholunate dissociation. The scapholunate dissociation. The two bones have gone away from each other, right? The scapholunate dissociation. What do you call that? The scaphoid and lunate going away from each other. What is that sign called as? It is called as Terry Thomas sign. It is called as what? The Terry Thomas sign. Remember the gap between the front two teeth, right? The people who have got the gap between front two teeth, that is what Terry Thomas had. And Terry Thomas was a English comedian, the UK based comedian. And the appearance of his two teeth, like the gap between his two teeth, was called by his name, right? So scaphoid and lunate, when they're going away from each other, it is called as the Terry Thomas sign. Okay, that is called as Terry Thomas sign. Scapholunate dissociation. Please remember that. Coming on to the spinal area. Now, what do we appreciate in this spine? If you join the anterior margin of all the vertebral bodies, what do you can make out? That this particular vertebra has moved ahead of the lower vertebra, right? This upper vertebra, it has moved ahead of the lower vertebra. And whenever any vertebral body, whenever any vertebral body slips over another vertebral body, what do we call it? Tom Tenney. It is not Tom Tenney, it is Terry Thomas. The previous one was Terry Thomas. Okay, now about this one, it is when any vertebral body slips over other vertebral body. What do we call it? What do we call it? We call it spondylo. We call it spondylolisthesis. Now, what is the meaning of this word? Spondylolisthesis. See, the word spondylo means what? You can remember from the classroom notes that spondylo is for what? It is for vertebra, right? And listhesis is what? What is the meaning of this word listhesis? Listhesis means to slip. So whenever any vertebral body slips over other vertebral body, what do we call it? Spondylolisthesis, right? It is called as spondylolisthesis. It can happen at any level. And when spondylolisthesis happens of the C2 vertebral body over C3 vertebral body, when listhesis happens of C2 vertebral body over C3 vertebral body, we call it what injury? Yes, you're right. Absolutely, you are right. Yes, it is called as hangman's fracture, right? That is called as hangman's fracture. So I must tell you this thing here, that for the reason for hangman's fracture, the mobility, the C2 sliding over C3, this is called as hangman's. But more common, this finding will be seen in the cases of RTS also, not only in judicial hanging. In the RTS also we do find them, right? That is spondylolisthesis. All right, look at this one. What do we see in this picture? The head is going back and then it is going in front, right? And the pressure is happening onto the neck area. So now this is a cervical spine injury. What do we see here? The neck going back and suddenly coming in front. So hyperextension followed by sudden flexion. What do we call that? What do you call that? This is whiplash, right? That is whiplash injury. Hyperextension followed by sudden flexion, like that. Okay, hyperextension followed by sudden flexion, that is whiplash injury. All right, so whiplash is basically also called as the sprained neck. Whiplash is also called as the sprained neck. Okay, so whiplash injury or the sprained neck. All right, the whiplash injury or the sprained neck, the cervical spine injury. Okay, that has to be cervical spine injury. All right, let's see next one. Very, very important image. Next one, and you have to identify what is the pathology here. Can somebody say what is the pathology here? Can somebody say what is the pathology here? You can see the sacrum. You can see the sacrum, and then you can see this as the vertebra, right? And you can see this is the L5 body and this is sacrum body. And what is happening here? The L5 has moved over sacrum. And what did we call that situation? When one of the vertebra slips over another vertebra, what do you call that? Spondylolisthesis, right? So this typical presentation of the L5 slipping over S1 is called as what? Spondylolisthesis. One vertebral body slipping over another vertebral body, it is listhesis, and it is very common at L4 L5 area, L5 S1 area. Okay, so please do remember the listhesis is best seen in which view of the spine, the vertebra? It is a lateral view which can show you the slip. That's a very, very logical point, right? The spondylolisthesis is best seen in the lateral view of the spine. Okay, you should be very, very clear about this point. Happened. Okay, we should be very, very clear about this point. Let me just go to the image. Yeah, so we are here. Then we have this one, this image, and I am sure each one of you can easily identify it. What is the problem here? This lateral deviation of the spine, this lateral deviation of the spine is called as what? Scoliosis, right? What is scoliosis? How to define scoliosis? It is lateral deviation. It is a lateral deviation of vertebra. It is a lateral deviation of vertebra. And if they ask you very, very specifically, you should be very, very clear here. Lateral deviation of vertebra with rotation also, right? With rotation of vertebra. So lateral deviation of vertebra with rotation. Lateral deviation of vertebra with rotation. That is scoliosis. That would be scoliosis. So lateral deviation of vertebra with rotation. Okay, that is scoliosis. And whenever you are talking about scoliosis, how do we measure the angle of scoliosis? What is the angle that we use? The angle to measure the degree of scoliosis, when you measure the upper part of vertebra, lower part of vertebra, and you draw perpendiculars to them like that, what is the angle do we call that? The angle for scoliosis, the angle for scoliosis is Cobb's, right? The angle to know the degree of scoliosis is called as Cobb's angle. That is called as Cobb's angle. So lateral deviation of vertebra with rotation, and that is Cobb's angle. Should be clear. Another very important image. What what do we appreciate here? What do we appreciate? The child is showing you some sort of scoliosis on his back, and a child is having a pressure effect onto the chin, pubic area, occiput, iliac area like that. What is this kind of brace or splint called as? This is the deformity, the trouble with which the child is suffering from is definitely scoliosis, and a splint system has been given to him. What is that splint system? What is that splint system? This is called as Milwaukee. This is called as Milwaukee, right? This is Milwaukee brace. So scoliosis is Milwaukee brace, treated by Milwaukee brace in a child, right? This appliance that you see this child is wearing is called as Milwaukee brace, which is used in a child for scoliotic curve, which is used in the child for scoliotic deformity. All right. Then we have other two images. Another one very important from the image point of view for your exams. Here you can see the child is being hanged like this with the overhead beam, right? So what is that called as? This appliance is called as gallows traction, right? This appliance is, what do you call that? Gallows traction. And this gallows traction is given to whom? It is given to any child who has got a fracture shaft of femur, right? At what age? Less than 2 years of age. Please remember, we don't give this appliance to any child who is more than 2 years of age. So gallows traction for fracture shaft of femur. This SOF is for shaft of femur only, right? This is for the shaft of femur. So any child who has got a fracture shaft of femur, any child less than 2 years of age, they can be managed by gallows, right? This one, the other picture that you see is called as Pavlik harness. It is called as Pavlik harness. What is a Pavlik harness? It can be used for same problem, fracture shaft of femur in any child who is less than 6 months, right? Less than 6 months, we can use the harness, a band. Then after that, less than 2 years, we can use a gallows traction. Please remember the best treatment method for any child less than 5 years of age. Fracture shaft of femur. Any child with a fracture shaft of femur less than 5 years of age, the best management always can be done by hip spica. Please remember that. Okay, it can always be done by hip spica. Okay, so Pavlik harness in any child less than 6 months, any child less than 2 years, gallows, and any child less than five, the best management can be hip spica. Right? Till 5 years, yes, absolutely correct, Priyanshu. You're right. It has to be Pavlik. Yeah, this one is hip spica. Yes, you're right. Okay, so these are the management plans for the fracture shaft of the femur. Another very important image for your exam. This is from trauma itself again. So, what do we appreciate here? There are two parts of this patella, right? Fracture patella, fracture patella. And how many parts we have here in fracture patella? These are two parts. These are two parts. The fracture patella, two parts. Okay. And if they ask you what is the best management for this condition, what is the best treatment plan for this condition? What do you suggest? What is the best treatment plan? What do you suggest? What is the best treatment plan? The best treatment plan is tension band wiring. The best treatment plan is tension band wiring. What exactly is that tension band wiring? You remember? Yes, it is patella fracture, two-part fracture of patella, and it always requires surgery. It always requires surgery. You cannot conserve it. Not only K-wire, happy coffee pot. Okay, that's a nice name. So K-wire is not the only thing which you will apply. Along with the K-wire, you'll have to apply the stainless steel wire also, right? And that is why you call it tension band wiring. So both the questions are important. Identifying it, both the questions are important. Identifying it is important, no doubt. And after that, okay, all right, okay. After that, okay, so this is fracture patella, two part, and tension band wiring is the best management we have. Okay, so KP is there. He's saying orthopedics एक भी question इन वीडियो से आउट नहीं जाता. Last gen attempt 5 question came from one session. Okay, thank you so much KP for enlightening us. Okay, and that makes the session further more important. Okay, so that's nice. So now number 3, number 23 here, we have a fracture at the base of the fifth metatarsal. We have a fracture at the base of fifth metatarsal, right? And the tendon attached over here. So what do we call this fracture? The fracture at the base of fifth metatarsal. What do we call it? The Jones fracture, right? That is Jones fracture. And the tendon which is attached over here is which one? The tendon which is attached over here is which one? It is peroneus brevis, right? That is peroneus brevis. Okay. So Jones fracture, named after Robert Jones, the fracture of the base of fifth metatarsal, the fracture of the base of the fifth metatarsal, right? The fracture of the base of fifth metatarsal, that is Jones fracture. All right, that will be the Jones fracture. Then we have, yeah, coming on to the metabolic disorder slides. If they ask, if they give you some picture like this, where the full length of the spine is involved, where the full length of the spine is involved like this, and in between every vertebral level, in between the every vertebral level, what you can see, there is a depression. Can you all see that? And that is called as what? This typical is called as the codfish spine appearance. This is called as the codfish spine appearance. Where do we see that codfish spine appearance? The whole length of the vertebral column will be involved, and that is seen in osteoporosis. That is seen where? In osteoporosis, right? That would be seen in cases of osteoporosis. So codfish spine appearance is typical for osteoporosis. Please remember other points also about the codfish, that what is the most commonest site where we see appearance of codfish spine appearance. So codfish is best seen, codfish will be best seen in the lumbar area, definitely the maximum weight taking area, right? And therefore the vertebral spine, the spine part of the lumbar area is most commonly involved. And after that, the second most commonest involved area in osteoporosis, neck of femur, again the soft area, cancellous area. And then third commonest area to get involved in osteoporosis, it is distal radius. right? That is distal radius. So these are three areas which are most often involved in osteoporosis: lumbar area, neck, femur, distal radius, and the lumbar vertebra, neck, femur, and distal radius. Three most common areas, right? Perfect. Okay, so this is osteoporosis. Another important point about osteoporosis which I want to enlighten here itself is that the best way to diagnose osteoporosis will be the scanning of the bone mineral density. And what do we check there? We check for the DEXA scan, right? We check for the DEXA scan. And what is a DEXA scan? DEXA is dual energy X-ray absorptiometry. And in that DEXA scan, what is the T score to call it osteoporosis? The T score will be always less than minus 2.5, right? To call it a osteoporotic bone, it has to be less than 2.5, right? So this is okay, right? So this is osteoporosis. Next, if you find, this image has been like kind of reverted, it has gone upside down, right? So this is the acetabulum, this is the acetabulum, and this is the head of the femur. It has gone actually upside down. So you can see, if you just turn this image, if you can turn up your paper, you can see there is a fracture in the neck of the femur, right? There is a fracture in the neck of femur. You all can appreciate the fracture. And along with that, there is a lot of whiteness all around. Along with that, there is a lot of whiteness all around. This is called sclerosis, right? So fracture with sclerosis, fracture with sclerosis, right? Where do we see that? The fracture with sclerosis means the bone is trying to heal up, right? And still it is not getting healed up. Why so? This condition is what you call as the pseudo fracture or the loser zone. This is the condition where you see the fracture lined with lot of callus all around, but the bone doesn't heal up. And why does it happen? This happened due to lack of mineralization, and lack of mineralization in the adults is called as what? This is called as osteomalacia, right? So pseudo fracture or the loser zone will be seen in cases of osteomalacia. This is just a upside down moved x-ray, so please see it in a like upside down manner. Just turn up your paper and you can easily make it out. Perfect, right? You'll be able to easily make it out. Now, in the cases of osteomalacia, what is the meaning of this word osteomalacia? Osteo, you all know, is for the bones. And what is the meaning of this word malacia? Malacia means softening, right? Malacia means softening. All right. So when there is a softening of the bone, when there is a softening of the bone, the head of the femur and the acetabulum, they both have gone into the pelvic cavity, right? This is what happens when the bones are so soft and the person keeps on walking. And this kind of protrusion of the bone into the acetabulum has been described as what? It has been described as protrusio acetabuli. This has been described as protrusio acetabuli, were the other name for which is autopelvis. And again, this condition, I must remind you, the softening of the bone and this prominence or the protuberance or the protrusion of the bone into the pelvic area is autopelvis is seen in when the bone is soft, and the softening of the bone is called as osteomalacia. So osteomalacia can have two typical features. One is the protrusion of acetabulum or the pseudo fractures or the loser zone. We should be very, very clear about this, right? Another picture which can be given to you in the exam is a wavy kind of bone, wavy pattern kind of bone, right? You can see the severe deformity, severely deformed bone like this, severely deformed bone like this, right? And this severely deformed bone is seen when the bone is so soft that it bends to any side wherever the pressure is given. Where do we see that kind of softening of the bone? When the strength of the bone is not there. And who is going to give us the strength of the bone? It is given by protein. What is that condition in which the protein is defective? This condition, can somebody name? Yeah, it is softening. Absolutely, you're right. Can you name this condition when the protein is so defective it cannot give any support to the bone, any strength to the bone, and the bone is so soft it bends, it breaks, it heals, again it breaks. And what do we call that condition? This is a genetic defect of the protein. This is a genetic defect of collagen. What do we call this condition? Yes, it's OI. Perfect. Okay. The genetic defect of which collagen? The type 1 procollagen. The type 1 procollagen. Okay. And this is called as what? The disorder is called as osteogenesis imperfecta. Osteogenesis imperfecta. Okay. That is called as osteogenesis imperfecta. So genetic defect in type 1 collagen, it is osteogenesis imperfecta. Perfect. Okay. So you are going well, guys. So good to see that everybody knows so much about the images. Wonderful. Osteogenesis imperfecta, right? So absolutely correct. Another one from the vertebral area, where if you get this kind of picture in your exam, where you can see whiteness all around the vertebral body, whiteness all around the vertebral body, what do you call that? This kind of presentation is called as picture frame vertebra. This is called as the picture frame vertebra. Okay, that is called as picture frame vertebra. Where do we see this picture frame vertebra? This is seen in which condition? This is seen in Paget's disease. So in your exams, if you find one white vertebra with all the four margins white, then it has to be picture frame vertebra, which is typically seen in Paget's disease, right? And if you find another vertebra where only the upper part and lower part are white, only the upper and lower part are white, and central area here is black, like this. Okay, what do you call this kind of spine? This kind of spine is called as rugger jersey spine. This is called as the rugger jersey spine. And where do we find this rugger jersey spine? This is spine, usually we can find this in three conditions. What are those? One is osteopetrosis, right? One is osteopetrosis. Second one is the renal osteodystrophy. Second one is renal osteodystrophy. And the third one is the Brown's tumor, post hyperparathyroidism. That is Brown's tumor. So osteopetrosis, yes, Rugger, absolutely correct. It is Rugger jersey spine. So picture frame vertebra and Rugger jersey should be very, very clearly identified, right? Now, osteopetrosis is, Paget, is a disorder of the cell. Those who have learned the basic in our classroom, when you have made the notes from wherever you have made the notes, you should be very clear. Paget is a disorder of the cell, and so is the osteopetrosis disorder. Both are disorders of the cell. Now, when there is a hyperclastic activity followed by blastic activity, we get Pagetic changes. Okay, and when there is a defect in the osteoclast, they are not working at all. What do we get? We get osteopetrosis. And how does it look like when the clasts are not working? When the clasts are not working, only working cell is a blast. And if it is only blast, it has to make the bone white. And the osteo, that is why the osteopetrosis that is why the osteopetrosis is also known by what name? The name has to be the marble bone disease. It has to be the marble bone disease, right? Osteopetrosis, it has to be the marble bone disease. Okay, that is why, yes, hyperparathyroidism, Amit, not hyperthyroidism, hyperparathyroidism. And that is what Brown's tumor is. Okay, so this osteopetrosis that you see on the screen, it is going to make the bone absolutely white, which appears absolutely white like a marble. So it is called as a marble bone disease. Okay, so osteopetrosis brings what kind of vertebra we said? The Rugger jersey. And another cellular disorder, Paget's, bring what kind of vertebra? The picture frame. That is the difference. Okay, so if you get absolutely white bone, petrosis, the marble bone disease, defect in the class is not working. And when all the four margins are white, picture frame vertebra. Right? It should be very, very clear to everybody. All right, perfect. So smart surgeon is also here. Good to see you. Okay. So now coming on to the nerve injuries, very, very important ones, the nerve injuries. Now, if you get this kind of picture in your exam, where the arm is kept close to the body, it is an adducted arm, where the elbow is kept extended here, where the forearm is kept in pronation, and these all are making the limb go into internal rotation, right? What do you call that? This kind of hand? What do you call this kind of hand? It is called policeman's tip deformity. And where do we see that? When there is a upper roots injury, C5 and C6 root injury. What do you call that? This condition? It is called as the Erb's palsy, right? That is called as Erb's palsy. Okay, Erb's palsy. This is, please remember, this is the most commonest nerve injury. This is the most commonest nerve injury related to the delivery of the child. Whenever the delivery is being taken and the head of the baby is being extended, it is being pulled back, then that can create this kind of issue. That is Erb's palsy. All right. Then another neural injury which can produce three typical pictures that you see on the screen. What do you see on the first image? What do you see on the first image? That patient is able to flex all the other fingers, but index is not getting flexed. This is called as what? The pointing index sign, right? Ask the patient to flex all the fingers and he can't flex this index area, and that is pointing index sign. In the second, you can see the patient is lifting his thumb. The patient is lifting his thumb to touch the pen. What is the test here? The test is pen test, right? And for what muscle are we doing it? The pen test is being done for abductor pollicis, abductor pollicis brevis, right? And third one is what you can appreciate here. The person is trying to put along the index finger and the thumb, right? And ideally, the flexor here, the flexor digitorum profundus and the flexor pollicis longus, these two are not able to flex it properly, right? If they would have been able to flex, the person should have been making a okay like this. That should have been called as what? Okay sign, right? That should have been called as what? If FDP, if FDP and FPL are working fine, if they are working fine, what they make? I'm writing here, they make okay sign, right? They make okay sign, which is not happening here, which is not happening here, right? So what is the position as of now? That they are not able to flex and they stay extended like this, right? And this is the failure of the okay, is called as what? Froment sign. Failure of okay is called as what? Froment sign. Patient is not able to make a okay, right? Patient, okay, I can just remove it. This froment will be confusing here. This is froment is basically the flexion of the thumb only related to the book test. So let's forget it. I'm not putting that here. So this is the failure of the okay. So simply remember it as the failure of the okay. Now all the three are being done for which nerve? They all are being done for, please remember, they all are being done for median nerve. So most important points about the median nerve, please remember, if the median nerve is having a palsy, patient will not be able to flex the finger, index finger. Second is abductor pollicis brevis is the one which is supplied by median nerve, and the red flag. Please put the red flag here itself. Please put the red flag here itself. The other abductor muscle, which can be the MCQ for the exam, the abductor pollicis longus, is getting a supply from which one? It gets a supply from radial nerve, right? It gets a supply from the radial nerve. All right. So this is the abductor pollicis longus and the radial nerve. Okay. Brevis is the one which we check in median nerve, and longus is for the radial nerve. And okay sign is definitely for your median nerve only. Now, whenever one other thing which I want to, yeah, that is the next image. I'm putting in the next image only. So please do remember about APL, pointing index, the pen test, and the OK sign. These have been your repeated question. And the format which I was telling you about is for the next image. I have kept it here, the next image. So whenever you want to test now thumb, you have already mentioned here. In the thumb, we have mentioned the abductor muscles here, brevis also, longus also. Now, what is the other muscle we have? There is the adductor pollicis, right? If you wish to check for adductor pollicis, if you want to check for adductor pollicis, what you do now? Adductor pollicis, first of all, please remember, adductor pollicis is getting a supply from which nerve? Not the median nerve, it is from the ulnar nerve. Adductor pollicis gets a supply from the ulnar nerve, right? Whenever the ulnar nerve is paralyzed, adductor will not be working, and then the patient will be using the median nerve, that is the flexor pollicis, which I was telling you the previous step, right? So this is the use of flexor pollicis. This is the flexor pollicis is used to hold the object, right? And now this sign will be called as what? The Froment sign. This sign is the Froment sign, okay? And holding something between the thumb and the fingers has been called as by what name we have called it? It is called as book test, right? That is called as the book test. Absolutely correct, right? That is called as a book test. So median nerve test, ulnar nerve, the most important test is the adductor pollicis, where you ask the patient to hold the object between the thumb and the fingers, between the thumb and the fingers, right? So please do remember, very important images, very important images. Now, whenever somebody has got a ulnar nerve injury, usually the fingers going to claw, right? And to extend the fingers, what we do, we bend them at the metacarpal area, and these are called as what? Knuckles, right? So you are bending the knuckles, you are bending the knuckles to get the length for the fingers, right? So knuckles being bent, so it is called as a knuckle bender splint. Okay, it is being called as what? The knuckle bender splint. And where do we use knuckle bender splint? These are used whenever there is a, these are being used whenever there is a claw hand, right? These are being used whenever there is a claw hand. So knuckle bender splint can be used in the conditions of claw hand, which can be a partial claw of ulnar nerve, which can be a complete claw of both the ulnar and the median nerve, or some other injury as well, which can lead to claw hand, right? So knuckle bender splint. Similarly, whenever somebody comes to you with a failure of extension of the wrist, whenever somebody comes to you with the failure of somebody comes to you with failure of extension of wrist area, right? What do we call that simply? It is called as the wrist drop, right? And why does that happen, wrist drop? It happens because of the radial nerve involvement, right? Now, in this case, the patient's wrist is falling down. The wrist of the patient is actually falling down. So what do we need to do? We need to keep it extended like this. We need to keep it extended, right? So this kind of splint, which is keeping the wrist extended, finger extended, is called as what? They are called as the cock-up splints. They are called as the cock-up splint, right? Now, one very, very important thing which I want to clarify here. One very important thing which I want to clarify here is any splint that you use for any problem, any splint that you use for any problem, splints can be of two types. Either it can be a static splint, it can be a dynamic splint, right? What is the difference? Static splint means like this, which is going to keep the limb in a fixed position, which is going to keep the limb in a fixed position. Like the first one, if I put it as image A, it is a static splint like this, right? No position change, nothing. But if you look at image B, you can very well appreciate that there are springs connected to it. Can you see that? There are springs connected to it. Spring means there is always a possibility of a mobilization. The limb, the joint can be easily mobilized. And that is why these kind of splints are called as dynamic splint. These splints are called as dynamic splint. So static splint or the dynamic splint, right? Static splint or the dynamic splint. So cock-up splint, elevated, static or dynamic. All right. So please do remember what is the meaning of dynamic, what is the meaning of static. Static is stagnant. Dynamic is dynamization, mobility, right? Let's see what else we have. Oh, we have another lesions over here. We have another lesions over here. So coming from the bone tumors, if you find a lesion like this and there is lot of whiteness all around, whiteness means the blastic activity. Blastic means this whiteness has to be there, okay? And a lesion surrounded by a lot of sclerosis. A lesion surrounded by a lot of sclerosis is nothing other than a blastic lesion. And that blastic lesion has to be what? The benign lesion of the osteoblast, okay? And that is osteoid osteoma. A benign lesion of the osteoblast, it has to be osteoid osteoma. A lesion surrounded by a lot of sclerosis is nothing other than the lesion of blast itself. And the benign lesion of blast is called as what? Osteoid osteoma, right? Second one. Second one, if you appreciate the proximal femur getting bent like this, if you see proximal femur getting bent like this, similar to the upper end of the stick, it shows that the bone is too soft, right? And what makes the bone soft? The fibrotic changes. Okay, and what is that lesion called as then? The lesion is called as the fibrous dysplasia, right? The lesion is called as fibrous dysplasia, and this bending of the bone, and the bending of the bone, what is the name it has been like given? It as the shepherd crook deformity. The upper end of the stick of a shepherd, it mimics the bone. The bone has been so soft, it has been bent like this, right? That is shepherd crook deformity. All right, so fibrous dysplasia, shepherd crook deformity. Don't mark it wrong. A very, very potential question for your exam. This one, I'm sure you all can recognize very, very easily. A polyp-like growth coming from the surface of the bone. What is that called as? A polyp-like growth coming from the surface of the bone. What is that called as? This is osteochondroma, right? That is osteochondroma. All right. So osteochondroma, the osteo is for the bone, and that is why it is visible. Then there is a chondroma. Chondro is what? Cartilage. So cartilage is not visible, but when you palpate it, it will be there as a cartilage cap, right? It is going to be there as a cartilage cap. So this one will be the cartilage cap, which never grows more than 2 centimeter. It always has to stay less than 2 centimeters. All right, that is osteochondroma, the bone and the cartilage, right? I hope everybody can recognize this. Everybody can recognize osteochondromas. Nothing to be marked wrong from these. Okay, so cartilage cap less than 2 centimeters. Yes, osteochondroma. Perfect. Perfect. Now see, if you get these two kind of lesions where you see a piece of bone falling into the cavity, piece of bone falling into the cavity. What do you call that? The fallen leaf sign or the fallen fragment sign. Fallen leaf sign or the fallen fragment sign. What is, where do we see that? It is seen in unicameral bone cyst, or what you also call as simple bone cyst. Unicameral bone cyst or the simple bone cyst. All right. And then we have a lesion where you can very well appreciate that epiphyseal area is free, right? And then you have a septated expansile lesion at metaphysis of the bone. This is metaphysis of the bone. So septated expansile lesion, septated expansile lesion where at metaphysis area, right? Septated expansile lesion, something like a soap bubble. Where do we see that soap bubble? GCT. But please remember, GCT occurs where? GCT occurs at epiphyseal area. The epiphysis is clean here. What it is supposed to be? It is supposed to be aneurysmal bone cyst, right? So cystic lesion of the bone, there are two. One is aneurysmal bone cyst, one is simple bone cyst. Simple bone cyst will have a piece of bone fallen into the cavity, that is fallen fragment sign. And aneurysmal bone cyst will have somewhat soap bubble appearance, kind of that expansile lesion, but at metaphyseal area, right? That would be giant cell tumor at epiphyseal area, aneurysmal bone cyst at metaphyseal area. I hope everybody remembers what is the basic approach, like we have read always in our classroom. The basic approach to a bone tumor is always look at 3 points. The first always has to be the location: epiphyseal, metaphyseal, and diphyseal. Right? Second point has to be identify the nature, whether it is benign or malignant. How will you come to know about that? So look at the periosteal response. Do you see any periosteal reaction in these two bones? Actually, no. And third will be the special feature. Special feature here is the soap bubble, but at metaphysis. Soap bubble at epiphysis would have been GCT. Something like this now. Something like this now. So you can see a septated, you can say appearance again, separated appearance again, but at epiphyseal area, right? And now this is what we call as the soap bubble. And soap bubble at epiphysis is signifying what? It is signifying giant cell tumor, right? Now, the second most important part is if in your exams, by chance, very uncommon thing to be asked, but yes, if they ever ask you, if there is a epiphyseal lesion given to you, and in the epiphyseal lesion, right, in the epiphyseal lesion, if the age of the child is like, if the child is there, right, if it is a immature skeleton, if it is a immature skeleton, then answer goes more common in favor of chondroblastoma, right? It goes more in favor of chondroblastoma. For example, in this image you can see there is a growth plate here which has been damaged by the lesion, which has been damaged by the lesion. And if it is a mature bone or a mature person, if it is a mature patient, right? Like this picture, you can see epiphyseal area, mature skeleton, the diagnosis most often goes in favor of giant cell tumor, right? That is a very basic way. So epiphyseal area, soap bubble, mature skeleton, GCT. Immature skeleton lesion, it has to be chondroblastoma. You can see the growth plate. Okay, perfect. Septic, smart surgeon, septic kya hai? It is not septic, it is okay. Now, other one which has been the past MCQ of your FMG exam as well, where you see the rays of sun coming out of the surface like this, that is called as what? The sunburst. And with the sunburst, you can see here that there is elevation of the periosteum. What do you call that? This one is called as Codman's triangle. And where do we see that? What is the tumor in which we see that? It is the osteosarcoma, right? It is osteosarcoma. Okay. And I remember one of the exam of FMG, it was broadly in the year 2020 somewhere. They have given one specimen like this, right? And they asked it, what is the most likely diagnosis? So again, go with the same step, same approach: epiphyseal, metaphyseal, diphyseal. If epiphyseal area you can see here is absolutely fine, that means epiphysis is clean. Okay, and the lesion is located where? At metaphyseal area. At metaphyseal area, what is that lesion which flares, destroys the cortex, show lot of periosteal reaction? It is only one. It is only one, that is osteosarcoma, right? Okay, that is osteosarcoma. Perfect. That is osteosarcoma. Okay, so don't forget the three steps I'm putting here for everyone. Whosoever has not been in the classroom with me or from wherever they have learned the bone tumors, please remember whenever there is a lesion of the bone, the basic approach to any bone tumor is very simple. First, look at the location, and you should know which all tumors occur at epiphyseal area, metaphyseal area, or diphyseal area. Second has to be to identify the nature of the tumor. Nature means whether it is a benign lesion or it is a aggressive lesion. And third point will always be to look for the special feature. To look for the special feature. Special feature means something which is unique for that particular lesion or the tumor, right? Something which is unique for that particular lesion or the tumor. That has to be very, very clear to all of us. All right, perfect. Let's see the next one. The next slide is showing you some lesion where you see multiple, layers of periosteum parallel to the bone. What do you call that? What do we call this lesion? The onion peel. And where do we see this kind of response, the onion peel response? It is seen in Ewing's sarcoma, right? If you see multiple layers of periosteum parallel to the, yeah, parallel to the periosteum or the cortex of the bone, this is seen in the cases of Ewing's sarcoma, right? That is a special feature we have. Okay, onion peel appearance, these multiple layers of periosteum parallel to the bone. That is onion peel appearance of the Ewing sarcoma. Then infection part. If you come across, and I can tell you, in the recent year examination of INI, and even it was a repeated question in the INI also, and a very basic question which is coming from infections, right? To identify the dead bone, identify the white bone, new bone, cloacas, like that. So whenever you have a dead piece of bone inside the cavity, what do you call that? That is called as sequestrum, right? And how do we define sequestrum? A dead bone which is surrounded by granulation tissue, that all the dead cell, all the organisms, bacteria, all over there, the dead cell, live cell, abscess, everything around that is the sequestrum. All the whiteness that you see, all this reactionary new bone formation that we see is what you call as involucrum, right? And whenever this granulation tissue will keep on expanding, it is going to perforate the involucrum somewhere. And that opening in the involucrum will be called as what? It will be called as cloaca. And these three are seen in which condition? These three are seen in the cases of chronic osteomyelitis. These three are seen in the cases of chronic osteomyelitis. Identify the sequestrum very, very well, and a very high probable question for your exams, right? Sequestrum, involucrum, and cloaca. So please identify sequestrum. If they say a particular person is coming to you with the abscess discharging from particular area of the bone, and x-ray is showing you a piece of bone like this, so a dead bone surrounded by granulation tissue has to be sequestrum. Okay, so when there is a hint given for the infection, it has to be sequestrum. All right, then we have a kind of image where they tell you that patient is having fever, backache, restriction of mobility, and so on, and they tell you that there are two vertebrae in between which the discal area is gone, where the discal area is destroyed, right? So now you know involvement of intervertebral disc space, decrease or loss of intervertebral disc space. Where do we see intervertebral disc space? Where do we see this? This is seen typically in the cases of the paradiscal involvement. We call this paradiscal involvement. Where do we see this? This is seen in the TB of the vertebrae, the tuberculosis of the spine. And what do we call that tuberculosis of the spine? This is called as the Pott's spine, right? That's called as Pott's spine. So decrease or loss of the intervertebral disc space, right? Typical one. Yes, it is tuberculosis. Perfect. And in the tuberculosis of the hip, what we can appreciate sometime is the proximal femur getting so destroyed that it is upriding. It is too much in the upriding, right? This is the gross shortening of the limb. There is gross shortening of the limb, and this gross shortening of the limb is going to give you a typical radiological finding. And what do we call this finding? Where there is the proximal femur going up and up and up and up. That is wandering acetabulum, right? And where do we see that? This is again seen in the tuberculosis of the hip area. Where do we see wandering acetabulum? The acetabulum which keeps on changing its position again and again and again and again. And it is going to happen again in the cases of tuberculosis of the hip area, right? So wandering acetabulum, hip is showing you severe destruction. Proximal femur has been pulled up, and the person is going to have gross shortening. Again, a feature of the tuberculosis, different stages we have, right? So, for the theory point of view, please don't forget to read about the stages of the TB hip. Okay, please do remember, recall from your notes the stages of the TB hip. They are very, very important. Okay, they are very, very important. Okay, next one. Next one is the deformity like this in the joint disorders. If you get this kind of picture where you see all the vertebrae are fused with each other, what do you call that condition? This is called as simply. the ankylosing, it is simply called as ankylosing spondylitic feature. Spondylitis, what is that feature called as? When all the vertebrae are fused like that, it is called as the bamboo spine appearance. It is called as the bamboo spine appearance, right? That is bamboo spine appearance. Where do we see that? In cases of ankylosing spondylitis, right? Upper deformity that you see, hyperextension of PIP here. This is the PIP, proximal IP joint, and the flexion of the DIP. Flexion of the DIP. What do we call that deformity? Flexion of DIP and hyperextension of PIP. It is called as swan neck. It is called as swan neck deformity, right? That is called as swan neck. And the flexion of PIP and hyperextension of DIP. See this? This is the reverse of that swan neck. And what do we call that? It is called as botanier deformity. And these swan neck and botanier deformity are called or are seen in which deformities, which disorder? We know both of them will be seen in the cases of rheumatoid arthritis. Both will be seen in the cases of rheumatoid arthritis. So swan neck deformity or the botanier deformity, both are seen in the cases of rheumatoid arthritis, right? So bamboo spine, ankylosing spondylitis, swan neck botanier in rheumatoid. Coming on to certain instruments, right, in orthopedics, which can be asked. So the first one that you see on the screen is like ice cream scoop. What do you call that? This is called as bone gouge, right? This is called as bone gouge. So whenever you have to take a graft from inside the bone, you can put it onto the bone and you can go deeper in, right, to take out a graft. So this is called bone gouge. And how to identify? There is a cup kind of like appearance it has. Okay, so it can go deep inside the bone and come out with some bone into it, the graft into it, the cancellous area, right? That is bone gouge. If you see this one, this one is called as the chisel, bone chisel. This bone chisel can be very well confused with the lower instrument, the lower one here, and this one is osteotome. What is the basic difference between the osteotome and the chisel? What is the basic difference? Look at this. The osteotome will be having both the edges sharp, this one as well as this one. This ends like this. Okay, this ends like this. This is osteotome. It is very sharp from both the ends, but chisel has to be sharp only from one edge and it is beveled from the upper edge like this. See, that is the difference, the chisel and the osteotome. Okay, and this chisel can again be confused with the similar looking another instrument we have like this, that is called as periosteum elevator. And how do I identify that this is periosteum elevator? It is going to have this thumb rest, right? This is called as the periosteum elevator. Whenever you are doing the plating, you want to clean up the surface of the bone, you have to use the periosteum elevator. So periosteum elevator, how to differentiate it from the chisel? And how to differentiate chisel from the osteotome, right? These three should be very, very clear. Okay, so periosteum elevator, chisel, and osteotome, right? This one that you see next one, like a crocodile mouth, this one is going to be a bone nibbler. This is bone nibbler. Okay, if you have to take out some extra pieces of the bone, if you have to take out like some sharp projection of the bone, so you can hold those projection, you can cut those projection and you can take it out. This is bone nibbler. Like the crocodile, its mouth has got some vacant area which can hold on the bone and they can bring it out, right? They are bone nibblers. Some splints, some important ones. So the very first image that you see over here is of which one? If you can identify, if you guys can identify, what is that? This one is Thomas splint. This one is Thomas splint. And why do we use Thomas splint? Where do we use Thomas splint? Whenever you want to stabilize the fracture shaft of the femur, right? It was designed by H.O. Thomas for his wife who was suffering from tuberculosis of the knee. So initially it was used to stabilize the TB knee, but now we use it to stabilize the fracture shaft of the femur. Okay. This kind of splint where the child is having some deformity like this, legs are deviated medially, and what do you call the deformity now? Deformity will be called as genu varum, right? It will be called as genu varum, and the splint which we are using here is called as mermaid splint. So for genu varum or genu valgum, for genu varum or the genu valgum, we can use the splint to correct the deformities of the legs, right? This is called as mermaid splint, used in which cases? Whenever the child is suffering from these deformities, and you know very well that the most commonest nutritional disorder which can create this deformity is rickets, which can create the deformity is rickets, right? And then we have, I think this is the last one we have. No, we have few more. So this one, is a splint where the lady is wearing a velcro in front. In front it is only velcro, nothing more than that. And on the back there is a splintage inside this splint here, inside this belt here. These are the splintages which will not allow the lady to bend forward like that. Okay, flexion deformity will not be allowed here. This one is giving this lady an advantage of the dorsal spine being blocked, the dorsal spine and the lumbar spine. So dorso-lumbar immobilization, dorso-lumbar immobilization, right? And this dorsal-lumbar immobilization, the splint is called as Taylor's brace. This is called as Taylor's brace. All right, this is Taylor's brace for dorsal-lumbar immobilization. Then we have another splint. Oh, I've shown you already. This is just a repeat of the previous one. We have already mentioned that this is Milwaukee brace. Why we use it? It is for the scoliotic curve. We have discussed that one. Right. This splint where the person is keeping the hand like this, like the wing of an aeroplane, right? It is called as aeroplane splint. And where do we use aeroplane splint? Aeroplane splint is used in the cases of the cervical, the basically brachial plexus injury, the root injuries. Okay, so that the patient doesn't develop any kind of wasting on this area. So, right, that is the aeroplane splint we have for upper root injury or the, yeah, this is not Boston. Azhar, this is not Boston. Boston is used in adolescents basically for treating the scoliotic patients, right? This one is the splint which is used when the patient is walking, he will not be able to control his ankle and ankle falls down, right? One very important topic I want you all to just see, go through your notes, is the injury to the common peroneal nerve. So, few points about common peroneal nerve. That common peroneal nerve most commonly is injured around the neck of fibula. Okay, it is around the neck of fibula. Whenever the common peroneal nerve is injured, the patient is going to lose the control of the foot and he walks with a foot drop, right? He walks with a foot drop. And if the patient is having a foot drop, how he has to walk? What will be his gait? The gait has to be always a high stepping gait. It has to be high stepping gait. Okay, all the three, they are very, very important. Okay, neck of fibula is the site, foot drop is the presentation, and patient's walk will be a high stepping gait. All right, that is the foot drop. And this splint will not allow the foot drop. And what kind of splint is this? Is this static or is this dynamic? So please remember, it has to be a static splint, right? It is not allowing any mobility, so it has to be static one. And then we have, yeah, then we have two shoes connected to each other by a bar. Where do we use these shoes? These are used in the patients of CTV. And what do we call them? These are called as the Dennis Brown splint. Where do we use it? In the cases of CTV. Once you have corrected the foot, after correction, the maintenance has to be done, and that maintenance is achieved by the Dennis Brown splint. Right? That is the CTV splint or the Dennis Brown splint, which is not the shoe. Shoes will be given when the child starts walking. It is only for the correction. Right? So, guys, these are 55, 56, 57 images, and this is from our side to all of you, those who are our daily batch students. We have definitely met in the classroom, and today it was a plan that we will be meeting you, me, ma'am, and other faculties will be meeting you at the classroom. Dr. Ajat was there, but anyhow, today the session, every session has to be online because of certain glitches, but that's absolutely fine. So I wish you all the very, very best, guys. This is from your mentor duo, from Sakshi ma'am's side, from my side. I wish you all the very, very best for your upcoming exam, right? And I'm pretty sure that you all have worked hard, you all have like studied very, very well, and just have faith on your preparation and keep that positive frame of mind while you're in the examination hall. Still we have got some time, right? Kind of last 10 days, 12 days, 15 days, like that. And in these 10, 15 days, I would not recommend any one of you to go with anything new. Just read whatever has been read till now. We have shared the list of PYTs of all the subjects. The PYQs are already there with you. DBMCI has conducted the one shot revision plan for FMG, where we have done the revision of all the 19 subject. So in any of the subject you are still weak, in any of the subject you feel like that I need to go through it again, then one shot is the best way. I can tell you, all our faculties have concised the content so well that there can be no question which can come out of that like session in your examination. So any of the subject, if it is weak, do not hesitate to revise that subject again, right? Just go through it and don't go to the exam without revising that, okay, my one subject is bad and I'm leaving it. Don't leave it. Still, you have time. Just prepare well and have confidence in your preparation. Have faith in yourself, right? You have been working so hard. So now it is a time that you should trust yourself. Okay. So no negative thoughts, no negative thoughts, and you are going to do it. Tell your mind every time you get up in the morning, every night before you go to sleep, tell yourself that you are going to do it and you can 100% do it, right? So stay positive, stay hopeful, and yes, waiting to hear from you, all of you, after your results, right? So all the very best to all of you guys. Thank you so much. The PDF is already there in the Triple S group. The PDF is already there in our yeah, PDF is already there, guys. It is, if you are a part of the Triple S group, it is already there. If you are a part of our DBMCA 360-degree plan, Yash has already shared the file with you. So please go through it. The file is already there, and make some good notes and just go for it, and you are going to do it, right? So thank you so much everyone for this session, and this session is going to stay here on the YouTube channel so that you can see it again, and you can oh, what happened? Right. So you can just make the full utilization of this session, and you can just see it again in case you want to do that. Right. Thank you so much. All the very best to all of you.